Now I invite Dr. Arshee Ahmed to take us through anterior uveitis. Over to you, ma'am.
A very good morning to all of you. So moving over from retina to a bit of uveitis now. So I'll be speaking to you on anterior uveitis, and then Dr. Partho will follow it up with posterior uveitis. So the objectives of this lecture are for you to understand the basic anatomy of the uveal tract, the sun classification, focus on anterior uveitis with case-based learning. So as you all know, the basic anatomy of the uveal tract, it is important to know that from anterior to posterior, you have the iris, the ciliary body, and the choroid. Now, why is it important here? So that you understand why the sun classification was proposed. This was proposed in 2004 to help you understand that the primary localization of the site of inflammation will help you giving an anatomical diagnosis and guide your investigations and management. So when inflammation is localized in this part of the eye, that is in front of the iris in the anterior chamber, it is called as anterior uveitis. So anterior uveitis itself can be classified into iritis, iridocyclitis or cyclitis. That is if the iris, the anterior part of the ciliary body, or both are involved. So when you see a patient on the slit lamp, how will you see that this patient has anterior uveitis? So the sign cordon on is that you look for the presence of cells and flare. So you have made the patient sit at the slit lamp, and what is it that you look for? So this is a brief video which shows you make a slit section, you have looked at the endothelium, increase the illumination and magnification to maximum, have a dark room, reduce the size of the slit to 2 millimeters into 1 millimeter, and make this optical section here, and in that you look for the presence of cells and flare. The same beam, if you focus behind the lens, you look at the anterior vitreous, and that is where you would look for anterior vitreous cells or pigments. So how do cells and flare look? So the first picture shows you cells, which are bright, mobile particles in the optical slit that you're seeing, whereas flare would appear as a haze in that particular region. So as you all know, these phenomena are visible to you because the normally clear aqueous starts having the presence of cells or increased protein because of a breakdown of the blood aqueous barrier. So the sun criteria also, the sun classification tells you how to grade AC cells and flare. So this basically helps in prognostication. How will you say that this patient has improved with treatment or has worsened or needs adjustment in therapy? So if you can grade it objectively with follow-ups, you can monitor the patient well. Laser flare photometry is another objective way of assessing the presence of flare. So this is the first case. Let's talk about it. 30-year-old male patient comes to you with sudden onset pain and redness. You see this patient in the emergency. You see the clinical signs. As you see here, there is a lot of ciliary congestion, mid-dilated pupil, cells in the anterior chamber. A normal fundus. What would you want to ask this patient? This is the first episode. No prior history of similar episodes. I think I heard trauma. So that is the answer here. Ask for a history of trauma. If you're in the emergency at night, you see a patient with sudden onset uveitis, no prior history, ask for a history of trauma. So this patient has traumatic anterior uveitis. The same photograph in a retro illumination. What do you see? You see sphincter tears. There are sphincter tears on the margin of the pupil. So look for signs of trauma. So traumatic anterior uveitis is a self-limiting condition. You treat them with topical steroids and cycloplegic mydriatics, they usually settle down. But the most important thing here is always have a look at the fundus. You may have other signs like commotio retinae, retinal tears, retinal detachments. So it is very important that the posterior segment is seen. Follow up these patients closely for IOP issues as well. So the points to learn from a case of traumatic anterior uveitis: ask for a history of trauma in all cases. Look for other telltale signs of trauma. Look at the ocular adnexa, the pupil. They may have angle recession. They may have a traumatic cataract, commotio retinae, and even JRTs. So traumatic anterior uveitis can happen in any age group. It is self-limiting. A clear inciting history will be there. It is up to you to ask for it. And no systemic investigations are required. Now the second case, a 40-year-old patient has recurrent episodes of bilateral pain and redness since the last 2 years. This particular eye is affected since 3 days. He has a progressive worsening of symptoms since onset. The fundus was visible but was hazy. What do you ask for? So for this patient, ask for a history of backaches. This patient has a history of lower backaches which worsens on inactivity. So what are you dealing with? Yes, so now it becomes clear. So history taking is very, very important when you are seeing a patient with uveitis. It helps you differentiate and look for specific tests, specific investigations. So this is HLA-B27 uveitis and classically known to be acute, anterior, fibrinous and recurrent in nature. So the management is straightforward. They need intensive topicals. There is no point in starting them on 6 times a day Predfort. It is not going to come down with that. Give them intensive topicals maybe every 15 minutes to begin with, and then hourly. The use of cycloplegic mid-reactors is very important to break down the synechiae which may have formed. So this is the photograph of the same patient post-treatment. Systemic investigation or systemic consultation is important, and have a rheumatologist to see the patient and add treatment like oral steroids, immunosuppressives, biologics, and even JAK inhibitors depending on the severity of the disease. So points to learn: acute onset, dramatic presentation, young to middle-aged males, associated history of spondyloarthropathy. You may see these patients to be having limited neck movements or neck stiffness even when you're seeing them on the slit lamp. So always be on the lookout for that particular sign in such a patient. Aggressive topical treatment and recurrences are very common. These patients also tend to get a lot of complications because it is a recurrent disease. So as an extra bonus, you can also learn now the other causes of hypopyon uveitis: Behçet's disease, endophthalmitis, drug-related causes, a pseudo-hypopyon, pigmented hypopyon, you may see it in TB or even in listeria infections, and a blood-tinged hypopyon, especially if it is like a masquerade kind of a situation. So these are other causes which you should be aware of. So next case, 40-year-old female, has had 2 episodes prior of pain and redness with blurring of vision. When we see this patient, pressure was okay, but the history shows she was locally noted to have high IOP in the first 2 episodes. So you see ciliary congestion, KPs and cells, a normal fundus. Any thoughts? High IOP, anterior uveitis. Perfect. So this is Possner-Schlossman syndrome. So when you see this particular case, you will treat the uveitis, but you additionally treat the glaucoma as well. So you treat the anterior uveitis based on the degree of reaction. These patients may require invasive testing. So you can do an anterior chamber tap for paracentesis to look for PCR testing. These patients may require the use of long-term treatment. So remember to use softer steroids later on, like fluorometholone or loteprednisolone. So the points to learn from this case: how does IOP fluctuate in patients with anterior uveitis? So either it could be high, it could also be low. So high IOP in uveitis, think of viral uveitis, toxoplasma, VKH and PSS as we saw. Low IOP on the other hand could be present in any acute case or even traumatic cases. In chronic cases on the other hand, it can happen because of a ciliary body traction or shutdown. Next patient, a 70-year-old female, comes to you with sudden onset blurring of vision in the right eye. She has a history of fever 3 weeks earlier. So again, you see a congested eye, you see KPs and cells, normal fundus. Any thoughts? Anything you would like to ask? Anything you would like to look for? Yes, infection is a good place to start. So step back and have a look at the patient. What do you see on the tip of the nose and on the same side of the face? So think of herpes zoster ophthalmicus. We cannot look at the patient just at the slit lamp. Look at the patient, ask for a history of any skin issues. At the same time, she had the fever, she had the rashes, she took treatment, she forgot about it. 3 weeks later, she has eye trouble. So she may not really bring it up to you, but it is important to ask for a history of skin involvement, especially when you see patients at extremes of age. So the treatment is again straightforward as far as anterior uveitis is concerned, but being zoster, she needs treatment with antiviral. Appropriate antivirals like either valcyclovir or acyclovir can be added. So the points to learn, of course, this photograph doesn't look like the Terminator photograph we have been seeing in between. It's a very painful condition, not as enjoyable as Terminator, but do remember that when you have extremes of age, it is important to think out of the box. Look at the patient as a whole. Appropriate systemic treatment should be added to your topical therapy. One more important thing you need to remember is do not start corticosteroids in these patients without starting your appropriate antibiotic antiviral therapy because there is a high risk of development of ARN if you do not treat with the appropriate antivirals. So 32-year-old male now, right eye blurring of vision since 6 months, no history of pain or redness, but is already on topical steroids, is already on oral steroids, which was started locally. What is your diagnosis? Yes, so this is Fuchs. So you should know that this is Fuchs. Why? Because you see a classical presentation of the heterochromic precipitates. So KP's characterization is very important when you are seeing a case of anterior uveitis. If they appear to be like diffuse, stellate, non-pigmented, you are dealing with the case of Fuchs. So this patient additionally you can also see has a PSC at the back over here. The KPs are distributed throughout. You can even see them at the top. Unlike the Arl's triangle, which is classically described for acute cases of anterior uveitis. So how do you manage them? Don't really have to do too much. Observation is key here. Intervene surgically if there is a visually significant PSC, but otherwise just observe, counsel the patient against use of frequent topical and oral steroids because that is just going to worsen the situation. Glaucoma is a big risk here in such patients, so counseling against use of steroids is very important. So the other points to learn, as we saw, is the presence of KPs. You may also have iris changes. Like in this photograph of a patient with Fuchs, you see a lot of nodules on the iris. So this is another important presentation. So let us learn a bit about iris nodules. So these are the other conditions which can present with nodules in the iris when you are having a case of anterior uveitis. It could be sarcoid. It could be something totally harmless like a Lischke nodule. It could be Down syndrome. Rarely, it could be seeding. Malignancies can also present with anterior uveitis. So when they happen on the border of the pupil, it is a coepes nodule. You see it on the surface of the iris, Busacca's nodules. You see it in the angle, a beautiful picture of nodules in the angle. So think of sarcoid anterior uveitis. So next case, 42-year-old patient, or acute red eye of 5 days duration. You see a lot of ciliary congestion, diffuse KPs, all pigmented, cells in the AC, normal fundus but high IOP. What is this? Anything you want to do? Any differentials in mind? So this actually requires probably an anterior chamber tap, and we are looking for something specific and we find it. This is viral anterior uveitis, a very, very classical presentation. So once you have made a diagnosis of viral anterior uveitis, again you will manage the uveitis part of it, the glaucoma part of it with your appropriate topicals, but you will also go on to add appropriate antiviral drugs. The use of corticosteroids is again dependent on how much inflammation you are seeing in the anterior and the posterior segment. So the points to learn, what are the various other features which viral uveitis can have? Look for corneal hypoesthesia, that is reduced corneal sensations, diffuse pigmented KPs. This photograph beautifully shows a pattern of sectoral iris atrophy, very typically seen in zoster. Then you may have high intraocular pressure, and I again reiterate, fundus evaluation is mandatory if you're seeing a case of viral uveitis. So this is the last case. I think it's a giveaway. A 10-year-old girl child, white deposits on the cornea and complaints of gradual loss of vision. She has a history of joint pain. So what are we seeing in this photograph? So this is band-shaped keratopathy. So you have this classical interpalpable deposition of calcium. You see even the Swiss hole appearance here at the periphery with a very thin area of clearing near the limbus. So this patient is to be investigated. You find her to be ANA positive and you make a diagnosis of JIA-associated uveitis. That is juvenile idiopathic arthritis. So the workup is straightforward, but the management is not. So this is one of those cases of anterior uveitis which will require chronic long-term treatment and follow-up. So the course is going to be fraught with a lot of complications along the way. This child already has come to you late with a BSK. So the most important thing is to treat with the appropriate immunosuppressives. Topical steroids alone are not going to treat anterior uveitis in JIA-associated uveitis. They need early rheumatology referral. Treat them with drugs like methotrexate, mycophenolate, step up to biologics if not responding to oral treatment. Another important thing to keep in mind here is amblyopia management, because if it's unilateral, they will develop amblyopia. Then surgical treatments in the form of either BSK removal or cataract surgery with or without IOL implantation can be planned once the inflammation is under control. So just to complete, you may also require other investigations in pediatric anterior uveitis if it is not fitting into the bracket of JIA uveitis. So the points to learn from this case: look for positives in both history and systemic examination. In this case, you ask for a history of joint pains, ask for joint swelling, and then refer them to a rheumatologist. Also think of infections and masquerades again, because this is extremes of age. This is a young patient. Long-term follow-up is required, as I mentioned. So another extra point to learn here is what are the other causes of white eye uveitis. So JIA-associated uveitis, Fuchs, Besset's. This patient is a 10-year-old kid who has presented with a white eye, loss of vision, and a cold hypopyon. So this is Besset's, and even masquerades. So these are the few masquerades, few malignancies which can present with anterior uveitis alone. Lastly, you can have drug-induced anterior uveitis. So these are the various drugs which can cause anterior uveitis. So this is the photograph of a patient who's on brimonidine and has developed anterior uveitis. So to recapitulate, you see a patient with anterior uveitis, look and ask for all these points. Look at the age of the patient, male or female. The laterality will give you a clue many times. The course of the disease is very important to understand, whether it is acute, chronic, or a recurrent disease. Etiology is up to you, for you to understand and to classify whether it is infectious or non-infectious. And this is just to sum it up. It could be infectious, various causes, non-infectious, so many. So this is not an exhaustive list by any chance, but these are the most common conditions you may see. And as you all know the Woods classification, try to characterize the anterior uveitis, whether it is granulomatous or non-granulomatous, because this will help you in narrowing down your differentials. So these are the various investigations one may need to do, but again, please note that it has to be very, very tailored, specific investigations. You are seeing a case of trauma, you are seeing a case of zoster, doesn't need to be investigated. You are seeing a patient with unilateral, non-granulomatous uveitis, first episode, no suggestive systemic history, doesn't need to be investigated. So investigate as and when required. So the basic principles of management, to sum it up, is tackle the inflammation with corticosteroids, tackle the pupil with cycloplegic mydriatics, investigate only to arrive at your diagnosis from your list of differential diagnosis, and then manage the patient accordingly. So anterior uveitis is inflammation only in the anterior segment. Look for cells. Flare is not what we treat. Flare is not an indicator of disease activity. Cells are. It is a diagnosis of exclusion. You cannot say a patient has anterior uveitis till you have seen the posterior segment. Thorough history taking again is of the utmost importance. Treatment, you can treat topically most of the times. Rarely complications may develop in the form of glaucoma, band-shaped keratopathy. Patient may go on to develop iris bombay because of posterior synechiae, complicated cataracts. Hypotony is the most dreaded complication in a patient with anterior uveitis, especially in JIA-associated and HLA-B27 uveitis. Thank you very much for patient listening, and all the very best to all of you. Thank you.